Welcome to Collegial Conversations with Diana Clark, the professional webinar series that offers clinical and personal perspectives on issues that are common, but often not talked about. Here is today's Collegial Conversation.
Thank you for joining a Collegial Conversation with Diana Clark. Joining Diana today is Dr. Jon Stevens. Dr. Stevens is a Harvard-trained psychiatrist with 15 years of experience in both inpatient hospitals and outpatient settings. He is a recognized leader in personalized mental health care and is highly skilled in medication management. Dr. Stevens is the founder of Psych Insight, a concierge private practice based in Houston, Texas. Today, Diana and Dr. Stevens will be discussing the psychological impact weight loss has on patients. Thank you for joining us, Dr. Stevens. I will now pass the conversation over to Diana.
Thanks, Laura.
Thanks, Laura. So I want to talk about the two movements that seem to be going hand in hand in our country for just a second, just before we talk about obesity, because I think it frames the conversation a little bit better, if you're willing. And that one conversation is healthy at any size and then obesity standards. So how do we reckon with both of those movements and treat people in holistic ways?
I think those are both important, Diana, but I think it's really the lens you're looking at that will help you to determine which approach to take. There's a lot of stigma in society, and the people I work with that face both mental health diagnoses and a diagnosis of overweight and obesity face a double stigma. So we want to make sure that any diagnosis or treatment plan that we come up with together collaboratively in the office does not perpetuate or ingrain that stigma just because they are having medical complications of their obesity, whether it's joint pain, whether it's a new diagnosis of diabetes or high blood pressure or cholesterol, whatever it is, or just self-esteem. They don't like that they can't fit in their old clothing. We want to make sure that that's taken in a non-judgmental, collaborative approach. And whatever size they end up at, or they find themselves at, it's all right to feel that they were, at least it's part of that collaborative process and not some judgment that, okay, you didn't get to a size 4 when that was your goal at the beginning, and that maybe their own goal, or maybe that's what their parents told them. And it's such a huge question, deceptively simple question, hard answer.
Right. And it is a complicated conversation because we are changing size in America. So what is the state of what we would call obesity in America, and what is the prediction for the future?
Well, it's not good. Currently, over 2/3 of Americans meet criteria for overweight or obesity. And at the current projections, half of Americans by 2030 will be clinically obese. Some authors and researchers have gone as far to say that in the very foreseeable future, everyone in the United States will be overweight or obese based on the current trends. I think that's overly dire based on some of the interventions we're going to talk about today. But when you really look at the explosion, especially in certain populations like children, certain ethnic minorities, certain genders, I mean, it's staggering. You see where these really kind of grim prognostications come from.
Mm-hmm. I get that. How did you get fascinated by this subject? Because I know you've had a wide range of experience and expertise. What about this kind of medicine appealed to you?
Well, I'm a clinician. I'm a psychiatrist and a child psychiatrist by training. And just in part of practice, dealing with some populations, like people with mood disorders like depression or bipolar disorder, schizophrenia, people with chronic psychosis, or autism populations, the medication interventions, which is my specialty, in many cases cause an increase in appetite or a change in metabolism such that people add weight. So sometimes I'll joke that I was part of the problem for a large part of my career. And during COVID, while sitting in the office or virtually with people, and people that were feeling bored, listless, lonely, in some cases depressed or very anxious, I would keep encouraging day after day, try something new, keep your brain active. What's something you wanted to do that you couldn't do? And this field, I've always been interested in and published on metabolism and side effects of medications, but I finally got a chance to get proper training, which was really nice, switched online. So I was able to do that and eventually get boarded in obesity medicine right after COVID. So it was a chance to, kind of walk the walk, not just talk the talk in the office, but also, I think, give my patients another avenue and not have to refer them out to a specialist who may not know their complicated mental health background and some of the family of origin issues and some of the stigma they've faced and some of the journey or the medicines that cause side effects like overweight and obesity. I think that gives some of my patients, just a new avenue of care.
Absolutely. And the stigma is real.
Absolutely.
And the stigma is promoted in part by the social media, all of those things. So they're really faced with obesity issues and weight issues constantly. So to not treat it is like, I don't know, being a marriage therapist and not including sex, right?
Yeah. Well, I will say, though, even in our field, I've had a couple of my colleagues, especially those that have their expertise is in eating disorders or body dysmorphia, that have looked askance at some of this. I have to admit, Diana, and maybe you could help me understand, because I think, unfortunately, if you're treating someone with severe anorexia, things like regular weights and sharing the weight and making, or BMI, which, is not something you want to focus on, because the individual is, through the nature of their illness, is already over-focused on a size or a BMI or a weight. So they're looking at, wait a minute, Jon, you're working on people like losing inches, losing weight, or losing adipose tissue, focusing on that in a very numerical, kind of transparent, methodical way, as something a little bit off-putting. But I remind them that while, yes, eating disorders are really amongst the most difficult disorders to treat, and you know that, Diana, I mean, in terms of morbidity and mortality, ultimately, unfortunately, because of the prevalence of obesity and overweight in our society, more people are dying or having their lives shortened or their functioning curtailed from that. So I think, to do this sensibly and collaboratively is the best way to go. But it doesn't come natural to certain in the mental health profession. I don't think there's that many psychiatrists across the country that are boarded in obesity medicine. I don't have exact numbers, but I think it's generally internal medicine doctors, endocrinologists, family physicians that are interested in this. And I think our field needs to be more aware of it.
And there is a genuine side effect on many medications for significant weight gain.
And
so to not address the weight gain while somebody is on these medications doesn't make sense to me either, because how can they remain on them in consistent ways if they're barraged with your body doesn't look the way it used to?
Well, many of my patients are surprised when they come to the office that I would even weigh them. Many people, when I ask them about, okay, you're on this antipsychotic medicine, you're on Abilify or Risperdal or Seroquel or whatever, or you're on a mood stabilizer like lithium or Depakote or Tegretol. What was your weight when you started? And what was your weight after first year or 2 years? Many times they'll say the psychiatrist didn't weigh them. Many patients, for the first time, when I'm taking measurements of their around their belly and their abdomen, are shocked. They've never had a psychiatrist do that, even though that's the recommended standard of care for when you're using certain medicines. So it's or asking them about what's your glucose the last time you went to your primary care, if they went to their primary care anytime recently. What's your hemoglobin A1C? What's your cholesterol? Many of my patients are shocked and said their psychiatrist previously never asked them.
Certain psychiatric medications actually do change cholesterol, isn't that right?
Absolutely. So we're talking about the fancy medical phrase is dyslipidemia. But many medicines out there, again, medicines that are commonly prescribed for depression or bipolar disorder or schizophrenia, even in some cases anxiety, can worsen the basic homeostasis in the body, the body's ability to generally, if you're eating the same diet and you're keeping the same exercise regimen, your cholesterol, your triglycerides will stay approximately the same. But these medicines, with the same diet, with the same exercise, in some cases dramatically throw off levels like triglycerides and throw off cholesterol, particularly LDL, or the bad cholesterol that people talk about. And when we talk about that, that's really important, because heart disease, now that we've come out of COVID, is still the number one killer in the United States, and including of patients with mental health illnesses. So we have to be really, really aware of that as providers, to not increase someone's burden or increase their risk of a heart attack.
Yes. How do you approach a sensitive subject like weight? Because it is a sensitive subject. It's one of the conversations we don't have with people either on either end of things, other than to say, you look great. Have you lost weight? How do we have conversations with people about weight that are stigma busting as opposed to shame inducing?
Yeah, and just even the way we were talking about before, you just mentioned is really not to focus on the look, like how someone looks. I'll almost never say, I'll talk, how are you feeling? And a lot of times the fatigue, or a patient came the other day, said, I come home from work and I feel magnetized to the couch. And again, as part of the overall treatment plan, in this case, she does have depression. Has gained weight, 40 pounds over the last couple of years, is not getting proper exercise, is probably consuming too much screen time on her phone, TV, etc. To a whole treatment plan. Yes, there is a weight in the office. Yes, we talk about changing the medicine so they don't have the metabolic burden of continuing to add weight. But then also talking about other strategy developments, medications that are out now that were not out a few years ago, that are really radically transforming the treatment of overweight and obesity. And it's
describe those medications and what they do and what the upside and the downside of the use of those.
Yeah, and weight loss medications have a rather spotty history. Anyone who's been on this journey, can remember medicines like, oh, there you go.
Yeah. I said it, fen-phen. I mean, it was, yeah.
And there's been many others. A lot of times they had appetite suppressing properties. And what happened is you go on the medicine, you do radically have a lower consumption, you lose weight, but you don't lose the right kind of weight. You're just basically, your body goes to a catabolic state. Catabolic is the opposite of anabolic. People probably know anabolic is anabolic steroids, build you up. Well, when you're starving, the body will break down muscle or fat or whatever it could get its hands on. So when you go to that catabolic state, people would lose skeletal muscle, they lose adipose tissue, and they get to they lose, but then they kind of plateau. They stop the appetite suppressant, and then they gain it all back. In some cases, more yo-yo dieting. And a lot of people have heard about that and things like that. The newer medicines that have come out, and again, they're kind of take on almost a faddish, appeal in popular media, social media, Hollywood celebrities, losing weight very quickly for whatever reason. Usually, it's not medical, more vanity and cosmetic. But these injectable medicines change metabolism. They increase insulin production, so you're not as hungry. They also slow gastric emptying, so you get fuller faster. These medicines were developed in large part for diabetes, but now have allowed people to lose, in some cases, dramatic amounts of weight to get to a new level of normalcy in their weight, which is really exciting for people.
So how do you address sort of it? Let's imagine, and I'm using a case study, you've got a woman who comes in who is, let's say, 80 pounds overweight. She's on schizophrenic. She's been on medications. This is where she is. She starts a regimen of medication to reduce her weight, if that's appropriate. And I imagine that goes through a rigorous, exploration about whether her mental health will sustain the weight loss. But that's the curious question. What happens when somebody changes size in the way you're talking about psychologically? Do we see a rebound in eating? Do we see something that would maintain weight instead of the result we're seeking?
It's different. I think what you're thinking of probably is some of the things that you and I probably seen for patients that have bariatric surgery, which for many years was the real go-to for losing substantial weight when weight had gotten to a point of obesity, and there's various levels of obesity, but basically diet and exercise were not moving the needle. So you talk about 80 pounds, and people would lose this weight, 80 pounds or more with bariatric surgery. But in many cases, psychologically, we're ill prepared for unwanted attention. And that's not just like, from the opposite gender. It can be from their own family, where it's like, oh my gosh, look, you look great and all that, but they weren't ready for that. And the comments, even sometimes the most hurtful comments, are actually from family members who are.
100%.
It's not necessarily just hooting or hollering on the street or anything like that, like you might think. It's from a family member, a loved one, who says something that just hits the wrong way. So that I've definitely seen. And of course, with surgery, there's just absorption issues. There's different lifestyle. And eventually I've seen people who've eaten through that, and in some cases gained back the weight.
Right.
The newer medicines I'm talking about, especially the injectable, what's called secrete medicines, that really change the metabolism. Yes, if you stop those, the weight could come back. But while on it, it really changes the relationship with food, Diana. And that's what's so interesting, because you start seeing all of the psychological aspects that really come up. I'll just give you a couple. I think you probably, yeah. So I've gotten calls, and just like I say, here are the side effects, whether it could be increased belching, feelings of fullness, or nausea. Anything else, give me a call. So I've had some urgent calls where people say, it's 11 o'clock and I haven't had breakfast. And I said, okay, what's going on? And they said, well, I haven't had breakfast, and breakfast is the most important meal of the day. And I said, well, who told you that? What do you mean?
Who said that? Right.
Or another, again, urgent calls. I didn't finish all the food on my plate. And, you're supposed to clean your plate. It's a sin not to clean your plate.
Wow.
So yeah, you see, like,
all those food messages come to the fore. Yes.
Yeah. And calls like that have come out, and you kind of realize that, or I just ate 2 meals. You have to have your 3 meals of the day, but not everyone needs that or wants that. So very, very interesting messages. So it has to be and I work with people from trainers to nutritionists, registered dietitians, in many cases therapists, to help people on that journey. I don't want your audience to think that it's just me doing everything, because it oftentimes takes a team. You start talking about that kind of, large weight, it starts to make, you need a new lifestyle that matches that in many cases.
I agree. So what didn't I ask you about medical interventions for weight loss?
Well, it's just sometimes I think people think it's an either or situation. Like I could do diet or exercise, or be, walking with my husband or friend, or I could do this. And in best cases, just like you and I have seen over in obviously mental health treatment, do I do therapy or do I do medicines? And it's not that kind of dichotomy. That's a false dichotomy. It's better marrying the two. Just like for depression or anxiety, depressions and the antidepressant medicines, and a good therapist or group therapy or family therapy for optimal weight loss and a new style, and to be sustainable, marrying good dietary practices, which many people do not know. And it's not related to intelligence. So people did not grow up with good messages about food. Good exercise. My barometer is 150 minutes a week of elevated heart rate. That doesn't mean, Diana, you need to go get your heavy, start doing deadlifts with your body weight. I see, yeah, but it really means getting your heart, getting a good sweat, which here in Houston, where I'm at, is very easy to do. Usually year round.
I was going to say, you don't even have to exercise to get a good sweat in Houston.
And then the medical interventions, if appropriate. And those are the people in my practice that have generally seen the best results, feel better when they go back to their primary care. Their blood sugar is lower, their cholesterol is lower, their triglycerides lower, their blood pressure is lower, the pressure on their joints in terms of daily pain, chronic pain is less, so they can maybe be on less medicine for chronic pain. You start to get that virtuous cycle, which unwinds that difficult cycle they had been in many cases, of a sedentary lifestyle with poor diet and mounting medical problems.
It's really an optimistic approach when you think about it. It is that people who have suffered with significant weight gain, and I'm imagining it's mostly significant weight gain, or at least a body that no longer resembles what they're used to have an avenue that is medically supported in addition to lifestyle. That's
absolutely
optimistic.
I feel it's optimistic. And the patients that come in, I've learned some things along the way that I did not learn in my training or early, where patients will set, in some cases, goals of 3 weight. The weight would just be like, I want to get back to where I was before COVID. And then I want to get back to the weight I was when I got married. And then okay, this is my all-time, like at college when I was really taking good care of myself. I was on the track team or I was on the swim team. And those patients who, kind of an easy first hurdle, a second hurdle, which is going to be hard. And then there's like the dream one. Those patients, which I wouldn't normally do because I look at it, okay, here's your body mass index. You're currently at 33. We want it down 25 or under. And that, again, I think was creating this, like for some people, like it have to be 80 pounds, which is very, very difficult for anyone through any means. So when you say, like, I just want to get down to this, or I just want to get into a size 12, that way I could shop in a regular store and have more clothing options, it actually seems to work better. So I've learned things along the way too, Dan. I'm still learning all the time. That's why I hope I said earlier, it's collaborative. It's a back and forth. Like, what do you want? Because one person's goal or their 3 goals might be different from the next person. So you want to, again, how to decrease the stigma, going back to your earlier question, is help people understand what they want and try to help them achieve that.
And not sort of impose upon them what our standard of beauty looks like.
Absolutely, because we talked about body mass index, but I have a lot of athletes come to my office. They're all my football players are technically obese. Some of them have 6% body fat and are ripped and have a body that I will never have. So that you can be thrown off by in certain conditions.
That's good to know. Well, Dr. Jon Stevens, thank you for joining me today on Collegial Conversations. I really appreciate the conversation.
Thanks for the conversation. Take care.
Take care.
Thank you for joining this webinar. Tune in to more webinars and sign up for our newsletter at o'connorpg.com.